Hello everyone, welcome to another episode of Ultrasound and Echocardiography. My name is Abhijit Barai. I am an emergency medicine consultant. Over the next half an hour or so, we are going to talk about LVOT VTI in shock. For those of you who have watched my previous videos on LVOT VTI, I'm pretty sure you have got some idea about the left ventricular outflow tract velocity time integral or LVOT VTI. In this particular video, we are going to talk about the usefulness of LVOT VTI in shock patients. Shock is a very common presentation in the emergency department and intensive care unit. We see this type of patients all the time, whether it is a septic shock, anaphylactic shock, hypovolemic shock, traumatic hemorrhagic shock, or a cardiac tamponade. It's not uncommon. We need to have a very good systematic approach in the assessment and management of this type of patients. That is exactly what we are going to do over the next 30 minutes. If you have any questions, please drop me a line in the comment section. You can write about any comments about this video, about this topic, and I will get back to you as soon as I can. So without further delay, let's get into further details. So this is what we'll do over the next 30 minutes. First of all, we'll talk about what is shock. What is the basics about shock? What are the different types of shock? How do they present? And why we should need to know about the LVOT VTI. We'll talk about what LVOT VTI is all about, how to measure them is very important, and of course the most important thing is how we can apply this LVOT VTI in different types of shock in their assessment as well as in their management. If you have not done already, please subscribe to the channel and write comments in the comment section so that I can clarify any questions if you have. So first thing first, what is shock? From the very early part of medical school, probably you are familiar with this term, shock. This can be a life-threatening, time-critical emergency. This can cause death of the patient if we do not diagnose it early and if we do not manage them early. That's why shock is considered as one of those category 1 or category 2 patients in the emergency department. So what is shock? Shock is essentially a condition when there is reduced tissue perfusion. So in the peripheral tissues of the vital organs like the brain, the heart, the kidneys, if the blood supply decreases, their function will be impaired, and that is what shock is all about. There are different types of shock. Different authors classify shock in different ways. In this presentation, we will keep it very simple. There are 4 different types of shock. Hypovolemic shock, when the blood volume is reduced. This can happen following severe diarrhea, vomiting, severe burn, or somebody may have a trauma, so hemorrhagic shock. So if the total volume of blood in the blood circulatory system is reduced, that is hypovolemic shock. The second type of shock is what we call a cardiogenic shock. So when there is normal volume of blood, but the heart cannot pump it to the vital organs, for example, in case of heart attack, in case of myocarditis, heart failure, that is cardiogenic shock. The third type of shock is a little complicated. It's called distributive type of shock. When the blood volume in the body is normal, but this blood is pulled in the peripheral circulation because of vasodilatation or venodilatation. For example, in case of anaphylactic shock, when there is so much histamine release that there is excessive amount of vasodilatation and the blood is pulled to the peripheral circulation, so the blood returning to the heart, the preload is reduced, and so the cardiac output is reduced, even if the heart is normal, even if the blood volume is normal. The another example is septic shock, which we see in the emergency department quite often. Septic shock is due to sepsis. They have got vasodilatation and that can cause redistribution of blood. This type of shock can be quite difficult to treat if we do not diagnose early. The fourth type of shock is obstructive shock, when there is obstruction of the blood vessels for some reason or the other. For example, it can be cardiac tamponade, it can be tension pneumothorax, it can be a large pulmonary embolism. So they have got normal heart function, normal blood volume, but because of obstruction in certain part of the circulatory system, there is not an adequate blood supply to the vital organs. So in any type of shock, it's very important that we monitor the patient very carefully. What is the heart rate? What is the blood pressure? What is the lactate? What is the urinary output? What is the breathing pattern? What is the GCS? What is the temperature? These are all the vital parameters that we need to know. One of the monitoring tool these days is the echocardiographic findings, especially the left ventricular outflow tract velocity time integral or LVOT VTI. That is exactly what we are going to talk about over the next few minutes. So what is this LVOT VTI? This is a very important slide and I am going to repeat this slide again after some animations and some clips. So what is LVOT VTI? In simple terms, the VTI is the distance that the blood is traveling through during the left ventricular contraction or cardiac cycle. I'll show you some clips to illustrate this a little further. So essentially, VTI is a distance that the blood is traveling to. By using Doppler, we can specifically measure the exact distance that particular column of blood is traveling. Now we need to know some formula to calculate this. So again, from the early part of medical school, probably you are aware of that cardiac output is equal to stroke volume multiplied by the heart rate. What is stroke volume? Stroke volume is the volume of blood that is pumped by the left ventricle during each cardiac cycle, during each systole. The assumption is that the left ventricular outflow tract is a cylinder. So in the cylinder, there should be a height and there should be an area. If we multiply the area with the height, that is the volume, that is the stroke volume. So if we further divide this formula, so stroke volume is LVOT area multiplied by LVOT VTI, or the distance or the height of the column. Now please don't get disheartened, it's a little complicated, but I'll show you some animations and it will be very simple over the next few slides. So what is LVOT VTI? What is the LVOT area? This is the diameter. If we know the diameter of the left ventricular outflow tract, we can measure this. The formula is area is pi multiplied by r square. So if we know the diameter and divided by 2 square root multiplied by pi, that is exactly what the area is. So once again, the LVOT area multiplied by the VTI multiplied by the heart rate, that is the cardiac output. In other terms, if we know the LVOT VTI, we can easily calculate the stroke volume. If we know the heart rate, we can easily calculate the cardiac output. I'm going to repeat the slide again to emphasize how important it is to understand this basic concept of LVOT VTI. Now, this is the fun part. I'm going to show you some animations and some real life patients clips so that you can understand this concept very well. This is the parasternal long axis view in one of the patients that I have seen a few months ago. So let's identify the anatomical structures. So this is the interventricular septum. Just above it, this is the right ventricular outflow tract, and this is the left ventricle. This is the pulmonary. This is the mitral valve. This is anterior leaflet, and this is the posterior leaflet here. This is the left atrium, and this is the aortic valve. This is the ascending aorta in this area. This is the descending thoracic aorta here. This area is considered as the left ventricular outflow tract. If you carefully look at it, it looks like a cylinder. Some people argue that it is not quite a cylinder, true, but for calculation purpose and to keep it simple, we can assume that this is a cylinder, just like this. This cylinder of blood is going through the aortic valve to the ascending aorta during every cardiac cycle, and it happens just like this. So when there is left ventricular contraction, this column of blood from the left ventricular outflow tract is traveling through the ascending aorta. Now if you carefully look at this cylinder, we can measure the exact volume of the cylinder by knowing two parameters. One is the left ventricular outflow tract diameter, and the other one is the height of the cylinder, which is the VTI. So in this area, you see that the distance between these two lines, this distance is the left ventricular outflow tract diameter. To keep the life simple, most people have got this LVOT diameter of 2 centimeter. Now let's do some calculations. So the area of this cylinder here is equal to pi multiplied by r square. R is the LVOT diameter, and as I've said, most people have got the LVOT diameter of 2 centimeter. So LVOT diameter by 2 multiplied by square multiplied by pi, that is the area of the cylinder. So if the diameter is 2 centimeter, 2 divided by 2 is 1, square is 1. So essentially the area is pi, which is 3.14 square centimeter. So all we need to know is what is the height of the cylinder, which is the VTI, to identify what the stroke volume is. Let me give you a couple of examples. A few months ago, I have seen one patient who is in shock after profuse amount of diarrhea and vomiting. Young patient, fit and well. His blood pressure was pretty low. Systolic blood pressure was 85 millimeter of mercury. I did a VTI, and the VTI was 10 centimeter. Because this is a very fit and well young patient, I assumed that the LVOT diameter is 2 centimeter. And I use this formula, and the stroke volume is pi multiplied by 10, which is 31.4 ml per cardiac cycle. So every time the left ventricle is contracting, 31 ml of blood is pumped to the systemic circulation, which is very low. Even if the heart rate is 100, we have got a cardiac output of about 3 liters, which is not good. So we have given a liter of saline, and we have measured the LVOT VTI again, and this time the VTI improved to 20 centimeter. 20 centimeter means that this person's stroke volume now is 3.1, which is pi, multiplied by 20, which is 62.8 ml. So that is significant improvement. So 60 to 80 ml stroke volume, that is pretty normal. So that is how you can measure the left ventricular outflow tract VTI. Let me give you a real life example to illustrate this further. To measure the LVOT VTI, you need to get the parasternal long axis view to measure the diameter, and then for VTI you need to go for the apical 5-chamber view. So in this patient, this is a 68-year-old female who came with some chest pain and shortness of breath, and we have done a bedside echocardiogram, and that is what we can find. First of all, this is the apex, this is the interventricular septum, this is the right ventricle here, this is the left ventricle here, the tricuspid valve is here, and the mitral valve is here. This is the right atrium, and this is the left atrium. Interatrial septum is here. Now if you look at this image, the first thing that will strike is that the right ventricle is little dilated than the left ventricle, and same is true for the atria. They are quite dilated as well. There is some sluggish movement, especially of the posterior leaflet of the mitral valve, so there may be some mitral stenosis there. But for this presentation, we will focus mostly on the LVOT VTI. Now this patient has got a CTPA done, and that confirms that she has got pulmonary embolism. So this is the LVOT VTI. So if you put the pulse wave Doppler, signal is just in the left ventricular outflow tract, just above the aortic valve, so it will be here. And if you press on the pulse wave Doppler button, then you will find that there are some waves coming like this. Now if you use the VTI measurement tool and then envelope the area of this, if you measure the envelope, then you will find that the VTI is 14.4 centimeter. The normal VTI is 18 to 22 centimeter. So this is not looking very good. This is below the normal VTI. So this is how the VTI is measured. I have some more other videos to explain how the VTI is measured. In this particular presentation, we will focus more on the application of the VTI in shock patients. So let me repeat the previous slide that we have talked about. So what is VTI? Once again, the VTI is the distance the blood is traveling through during the cardiac cycle, and we can use the Doppler technology, especially pulse wave Doppler, to measure the LVOT VTI. The formula here is that cardiac output is equal to stroke volume multiplied by the heart rate, and we can detect the stroke volume by LVOT area multiplied by LVOT VTI, and the area formula is pi multiplied by r square. R is the diameter divided by 2. So if we know the LVOT VTI, it will give us some idea about stroke volume, and also it will give us some idea about the cardiac output. So normal LVOT VTI is 18 centimeter to 22 centimeter. Why should we use the LVOT VTI in shock patients? First of all, this is a non-invasive measure. It's give us some real life, real time measurements. It helps us to guide the fluid resuscitation and the other therapeutic interventions. So good example is the patient that I have talked about, a patient who has got hypovolemic shock. We have checked the VTI, which is 10. We have given some fluid, checked the VTI again, and the VTI is improved. That is exactly what VTI should be used for. The other examples are, if somebody has got a PE, we can check the VTI, give the thrombolysis if required, check the VTI again after thrombolysis, and we will find that the VTI is improved. So that is when the VTI is so important in case of shock patients. The VTI can be useful to differentiate among the different types of shock, and the interventions that we are using, we can monitor the response to treatment in a dynamic way. So if we do the VTI only once, that's not going to be very helpful. The main idea is you do the VTI now, give some treatment, whether it is fluid, inotropes or thrombolysis, repeat the VTI another couple of times, and you see if there is change. If there is change, carry on with the intervention. If there is no change, think about something else. Now let's focus on each of the different types of shock. So first shock, the commonest type of shock that we see in the emergency department is hypovolemic shock. So what is hypovolemic shock? Hypovolemic shock is when the circulatory blood volume is reduced. Somebody might have severe diarrhea, vomiting. Somebody may have a parectal bleeding, or somebody may have some gynecological bleeding. Somebody may have a severe burn. Their blood volume is so much reduced that they develop hypovolemic shock. Typically, the LVOT VTI is less than 18 centimeter in these patients because their preload is very reduced. So why the LVOT VTI is important and how we are going to use it? We are going to use it by serial measurement of the LVOT VTI. As we have mentioned, that give some fluid, give some inotropes, see what happens with the LVOT VTI. If it improves, that's great. For example, in case of hypovolemic shock, if we do the LVOT VTI, give some IV fluid, and if there is increase in the LVOT VTI after the fluid, we know that this is fluid responsive, which means we can give some more fluid. On the other hand, even after giving some fluid, if there is no change, that means this person is not fluid responsive. If we give fluid, it's not going to help. Do something else. Might be some inotrope drugs, might be some other interventions. Let's talk about a second important type of shock, which is cardiogenic shock. Cardiogenic shock is that those life-threatening, time-critical emergencies when there is impaired cardiac function. A good example is a heart attack. A good example is myocardial myocarditis. A good example is the heart failure. This is the condition when there is a poor contractility of the cardiac muscle, so the LVOT VTI is reduced. Remember, LVOT VTI is a distance the blood is traveling. If the heart does not have enough power, the blood will not pass or move that far, which means the VTI will be reduced. LVOT VTI is used as a monitoring purpose by serial measurement. So if you give some inotropes, you can recheck the LVOT VTI to see how effective the inotropes are. If the inotropes are not effective, LVOT VTI will not change. However, after giving some inotropes, if the VTI improves, that's great. Give some more if required. We can also use the VTI in case of mechanical circulatory support like intra-aortic balloon pump and ECMO device. Let's talk about distributive type of shock. This can be a quite interesting type of shock because their blood volume is normal. Their heart usually has got normal cardiac contractility. However, because of the vasodilatation, the blood is pulled in the peripheral circulation and there is a maldistribution of blood flow. So the heart cannot pump enough blood, and that is why their cardiac output is usually changed. There are two different types of distributive shock, high output and low output. It can be a scenario that in a septic shock patient, their VTI is more than 22 centimeter. However, they have so much peripheral pooling of blood because of reduced systemic vascular resistance that they develop a state of shock. Usually, they are very tachycardic. They develop hyperdynamic state. The other type of condition is in case of distributive type of shock, their VTI, LVOT VTI is low because of the reduced cardiac function and inadequate preload. Like in case of the hypovolemic shock and sometimes in cardiogenic shock, the distributive shock can be affected by the LVOT VTI during fluid management and vasopressor therapy. The fourth type of shock is obstructive shock, when there is physical obstruction to the blood flow. A good example is a pulmonary embolism. A good example is a cardiac tamponade. A good example is a tension pneumothorax, when there is physical compression over the blood vessels, that the heart cannot pump blood to the vital organs. Again, in case of this type of conditions, the LVOT VTI is reduced because of the impaired left ventricular filling. To monitor the effectiveness of the intervention, we can use the LVOT VTI. For example, in a cardiac tamponade, you can check the VTI, you do the pericardiocentesis, check the VTI again, and you may find the VTI has improved, which means the pericardiocentesis is effective. Another example in case of the pulmonary embolism is that if you give thrombolysis, you may find that the VTI has improved after the thrombolysis. Now, what are the advantages of LVOT VTI? I hope that you have understood what I have told you so far. If you have any questions, please drop me a line in the comment section. The main advantage of the LVOT VTI is that it is non-invasive and it can be performed at the bedside. It is portable. It provides a real-time hemodynamic data. So as we are talking to the patient or talking to the nurse or the junior doctors, as we are giving them the instructions, we can actually find that there is some LVOT VTI numbers, and that can help us to guide us through to the next step of the management, which is phenomenal. Whether we do the fluid management or therapeutic intervention like a thrombolysis or giving some vasopressor support, we can take the decision based on the LVOT VTI. If we give some treatment, whether the person is responding to the treatment can be assessed through the LVOT VTI. We need to be aware of some limitations as well. So in case of LVOT VTI, the main limitation is that we need to have a good view, the apical 5-chamber view, and we need to have the precise measurement of the LVOT diameter and the Doppler alignment. Many of the new ultrasound machines have got the ability that manually we can steer the Doppler signals so that the Doppler signal will be parallel to the LVOT, but the old machines are a bit challenging. Diameter measurement, it can be again a bit tricky sometimes, but most people have got the LVOT diameter of 2 centimeter. The second limitation with LVOT VTI is that it does not provide the information on the systemic vascular resistance or the oxygen delivery. If we want to measure them, we need to do some invasive measurements, unfortunately. Remember that LVOT VTI should not be used on its own. It's a part of the whole bigger picture. It's a part of the clinical and laboratory parameters. So what is the clinical presentation? What is the history? What is the physical findings? What are the investigations? How the ECG is looking? What are the other vital parameters? Based on all of this, we can integrate the findings of the LVOT VTI for the decision making. So once again, LVOT VTI is a very useful and powerful tool for the assessment of time critical life-threatening emergencies in the emergency department and intensive care units. It gives us some idea about the stroke volume and cardiac output. We can differentiate different types of shock by applying this LVOT VTI, especially if we use the serial measurements. It can help us to guide us through the interventions and the therapeutic approaches. LVOT VTI is real-time, non-invasive monitoring, and it improves the outcome of the critically life-threatening conditions. Always use the LVOT VTI along with the other clinical assessments, the history, the physical examination, the other investigations, and that will give us a comprehensive care of the patients. There are a lot of works in this field. I have been working on a couple of projects, and I hope that we can get some further improvement of this topic. And if you have any questions, please drop me a line. You can send me an email or drop me a comment to my YouTube channel. I hope that you find this useful, and over the next few months I will be making some more videos on this topic. I hope that you watch them as well. Thank you very much for taking your time, and I hope to see you soon. Thank you. Bye for now.